Okay, good night. My name is Jade Bartley, here for a neurosurgery resident, and tonight I'll be presenting on the AOT-LIX classification system. Why did it move? So just a brief outline, I'll be going through evolution of systems that exist for thoracolumbar injuries. Then I'll just give a brief introduction about the classification, a description of the different aspects of the classification system, how it's an approach to its use in terms of the algorithm, and then a summary, and then my references. So thoracolumbar injuries are usually associated with high energy trauma, and they have a tendency to cause serious morbidity. As such, it's important for us to have a standardized classification system to allow us to easily and readily assess these patients with suspected injuries and as a guide for their management. Over the years, there are several classification systems that have been proposed as early as 1938 by our pioneer Watson Jones, who had used simple X-ray morphology of fractures and classified them into three categories. So simple fractures, simple wedge comminuted fractures, fracture dislocation, and hyperextension injuries. Moving forward, Nicol then also further subclassified fractures, and Nicol had basically stated that the stability of the spine is determined by the vertebral body, the intervertebral disc, as well as the interspinous ligament. And this allowed for more practical understanding of the thoracolumbar injuries. And he basically focused on injuries that are associated with worse functional outcomes. Fast forward in 1963, Holzworth introduced the concept of two-column system, so anterior and posterior system, and he further reinforced the importance of the posterior ligamentous complex and divided fractures into basically 5 categories based on the fracture pattern. So pure flexion, flexion rotation, extension, vertical compression, or a direct shearing force. And then in 1983, the Dennis three-column model, which was previously discussed, was introduced in that the spine was divided into anterior, middle, and posterior column. Also spoke about the potential instability and gave a more 3D morphological picture of fractures and a guide to their management. The only difference is that this gave a more hierarchical grading of injuries for thoracolumbar injuries. Moving on from the Dennis three classification system. However, this was very complex, had a lot of inter-observer, not really reliable, and it had multiple subtypes, which many physicians, spine surgeons, and non-spine surgeons had difficulty using. And so the spine study group in 2005 came up with the TLIX classification. And as previously mentioned in previous discussions, this was what, along with the AOT-LIX, is commonly used to classify thoracolumbar injuries. This included the morphology of the fracture, the posterior ligamentous complex integrity, as well as the patient's neurological status. And then based on that, the patients will be given a score, whether it's before, greater than 4, or a gray zone. And then that would help to guide management of these injuries. TLIX, however, had some drawbacks. And so they had issues in terms of the inter-observer reliability. It didn't really account for patient modifiers. The other criticism is that it was not as reproducible as the spine surgeons and non-spine surgeons would hope it to be. And so moving further forward is that a new classification system based on the AO-McGirl as well as the TLIX in 2005 was revised in 2013. And this is what I'll be speaking about. So the AO classification system, TLIX, was built upon the previous classification, as mentioned, the AO-McGirl in 1994. This was determined to be a pathomorphological classification. It was not as complex as the previously proposed AO-Magrel system, and it gave a balance between the descriptive detail of AO-Magrel as well as a simpler focus that the TLIX proposed. It's also provided, based on the fracture pattern, it provided a injury severity score that could have been calculated to further help physicians as to how to manage these patients, whether it should be non-operative versus operative. And importantly, this AO-TLIX classification system included patient modifiers, which really helped to make management of patients with these injuries more patient-centered, or I guess you could say more of a wholesome view. So you're not just thinking about the injury, but the patient on a whole. And that would determine whether or not, despite it having a high level of potential instability or stability, then based on the present modifiers, that would determine whether or not you will go ahead and operate on this patient. So it's pathomorphological, as I stated before. It really classifies fracture patterns based on the morphology, and that's really based on the forces acting on the spine. So compressive forces, axial torque, and distraction. There are at least 3 subgroups, type A through to type C, with increasing severity as you move from A to C. And under each group, you have further subgroups with increasing severity, from involving a structural component of the vertebral body versus a non-structural component. So moving along to discuss type A. So type A is really as a result of the compressive forces acting on the vertebral body, and it ranges from AO to A4, right? So AO is a non-structural injury. It's clinically insignificant. The patients may usually have pain, but there's no concern for the patient's stability. And so patients with this type of fracture, which is basically a fracture affecting the transverse process or spinous process, those patients can actually be managed non-operatively. Moving along, your A1, which is our wedge compression fracture, as you can, A1, as you can see here, it's usually a anterior wedge compression fracture. So it's a fracture that's affecting the superior end plate. There is no concern for the stability of the spine, and these patients can actually be managed non-operatively. A2 involves a fracture affecting both the superior and inferior end plate, as you can see here. Are you seeing my mouse?
Yep.
Yeah, sorry. So A2 involves both the superior and inferior end plates, as you can see here. And there is some concern for instability. It can also be, yes, that's A2. A3, however, denoted here, is basically a compressive fracture that goes throughout, it goes all the way to involve the posterior vertebral body, right? And it can be associated with fractures of the lamina, as well as there's no disruption to the tension band. So even though it's involving the entire superior end plate, the tension band, posterior tension band, is actually intact. And as I said before, it can be associated with a fracture affecting the lamina. A4, as you can see here on the sagittal view, is a burst fracture, right? So a complete burst fracture, while A3s are incomplete. So with the complete burst fracture A4, there's involvement of both the end plates, superior and inferior end plates. And they may also have an associated slip fracture through the lamina, as denoted. Where's my mouse? As denoted here. As denoted here. And there is concern for instability with A4 fractures, as the fracture usually affects the posterior tension band. Type B fractures are known as distraction. So that's a category, distraction. And it has at least 3 different subtypes. And it has to do with either failure of the anterior or posterior tension band. So B1, as denoted here, is what we call a chance fracture. So it has to do with osseous failure of the posterior tension band extending into the vertebral body. B2 is a posterior tension band or posterior ligamentous disruption. So you may see increase in the interspinous distance, right? Sorry. And it can affect multiple vertebrae compared to B1, which usually only affects a single vertebra. And then type B3 is what we call a hyperextension injury. So you may have disruption of the anterior as well as the posterior tension band, as you can see here. And this is just other pictorial examples of B1. As you can see, transosseous disrupting the posterior tension band, usually affecting only a single vertebral level. B2 can affect multiple vertebral levels and the posterior tension band is not intact. And you also have an associated fracture going through the lamina and the pedicle. And in type 3 is where you have disruption of the fracture line can be through the vertebral body extending into the intervertebral disc, or it can just be involving the intervertebral disc. And it's usually associated with a hyperextension injury. So type C fractures are usually the most severe, and it has to do with anything that displaces a cranial or caudal vertebral fracture segment in any plane. There are no subtypes, and it may have superimposed type A or type B injuries, which usually should be classified separately and not just classifying the fracture as a type C. But once seen, this would require operative intervention if it is that the patient has no contraindications. And this is just further pictorial view showing distraction, as you can see here. Neurological status was also considered and included in this fracture classification, thoraco-lumbar injury classification, and it ranges from NO to N4. So N0, neurologically intact patient. N1 is a patient who has a transient deficit, but it usually recovers by the time you have completed your exam. N2 speaks to a nerve root injury or radiculopathy. N3 speaks to incomplete spinal cord injury or cauda-equinal. N4 speaks to a complete spinal cord injury. And then NX is usually for a patient that you can't really determine the neurological status. So whether the patient has a concomitant head injury or sedation. Modifiers. So this actually helped to further guide management of patients, because based on the presence of or lack of certain factors, then this would affect management of patients in terms of operating or not. So M1, it has 2, M1 and M2. So M1 speaks to fractures with indeterminate posterior complex injury. And then M2 speaks to additional factors that would basically prevent you from going ahead and taking this patient to theater. So if the patient has any associated head injuries, overlying burns overlying the area, overlying the wound, osteoporosis, rheumatoid arthritis, cardiac issues, then those would actually preclude operating in these patients or make one hesitant. So based on this classification, the algorithm was proposed by the group, the spine study group, to basically help the physician, surgeons, or non-spine surgeons to approach these patients. And they usually recommend trying to identify the most severe and then moving down. So if there's any evidence of displacement or translation, then that will be a type C, which is most severe, would warrant intervention, surgical intervention. If no, then you would move down the algorithm looking for a type B. So whether there is tension band involvement, if so, is it just osseous? Is it osteoligamentous? Is it affecting only the posterior tension band? And then that will tell whether or not it's a B3, B2, or B1. And then if it is that the tension band is intact, then the least severe would be your type A. And then you have to further identify, is this a A4 versus a A3, or is this a A2? Because then A3, A4, depending on other factors, would warrant surgical intervention. And so that algorithm was proposed. Moving further along, based on the fracture patterns, the neurological status, as well as the presence or lack of modifiers, AO spine injury severity score was proposed, right? And this basically helps to determine how you'd go ahead and treat these patients. So type C, which is the most severe, you get the highest score of 8, which would warrant surgical intervention. So a score that's greater than 5 warrants surgical intervention. If it's less than 4, then that's conservative. So type 3 off the bat is surgical intervention once it is that the patient does not have a contraindication. Importantly, as it relates to neurological status, before, I don't know if you recall, the TLIX classification, the incomplete spinal cord injury was actually weighted more. But as you can see, based on this injury severity score, both incomplete and complete actually have the same score. So none does not weigh heavier in that. Regardless of whether the patient has an incomplete versus complete, then that would still warrant you intervening, ideally within 24 hours, to somewhat improve this patient's AJAS score, right? Comparison to other systems. So as mentioned before, moving from AO McGrail, which is actually more complex, it had at least 53 subtypes. In contrast to your TLIX, which was easy to use, it's simple. It takes into consideration the patient's neurological injury, the posterior ligamentous complex integrity, and it also gave you a scoring system that you could use to guide management of these patients, and it can be used in the pediatric population. The ATLIX classification, it combines the two, so it gave you a detailed approach, and it's simple to use. It consists of less subcategories in comparison to your AO McGrail. It takes into consideration the neurological injury, the posterior ligamentous complex integrity, patient-specific modifiers, which would help to preclude intervention for serious injuries, depending on whether or not the patient has any underlying health conditions, overlying burns that would prevent same. And it actually used imaging that was available in the emergency department. So TLIX actually relied on MRI to determine the integrity of the PLC versus TLIX, the AO TLIX classification, which solely relied on CT. The drawback is that you still have little awareness of this classification, and not many persons are still using SAME, and it's not validated for use in the pediatric population. From my research done, there was a study that I found by Barkella et al. That actually shows that the AOT LIX has a better standardized use of additional variables, such as dislocation, increased interspinous distance, and that's helped to further differentiate between type A and type B injuries. But since this was proposed as well, it's important to know whether or not it is reliable. Reliable meaning is it reliable in terms of reliability between the physicians, or intra-observer reliability. So are you able to classify patients in the same subgroups each time when used? And so this systematic review was done that looked at 12 studies. over the years, and it shows that the AO-TLIX classification system has actually been shown to be the most reliable of all the classification systems. It's just that between the A1 and B3 subtypes, there was much variation, but it's highly reliable, it's simple, and it's recommended to be used. And this systematic review basically supports its use in their approach to patients with thoracolumbar injuries. So summary, the AL classification strikes a balance between the AL's descriptive detail and TLIC's simpler objective focus on management. It provides an algorithm to manage patients solely based on CT scan images, which is most cases is readily available. It allows treatment algorithms to be more patient-tailored. So it doesn't just consider the injury, but it considers the patients as a whole. And it standardizes daily decision making, but should only be considered as a guide. It does not predict outcome in these patients. So yes, you have these classification system, but it does not mean that you need to follow them to the T. It should just be used as a guide. It also moves away from the 3-column theory and consider the spine as an anterior and posterior column, which is different from the Dennis 3-column model. And it's the most complete, most reliable of the classifications and suitable. And these are my references. Thank you.